Since you're recording on cardiovascular disorders, this will be our week 1. There's some cardiovascular risk factors that we can look at, some that are modifiable and some that are not modifiable. So there's the modifiable ones like your increased sodium, if you're smoking, if you have low potassium, which is lots of fruits and vegetables that contain potassium, and maybe we're having increased sodium levels, if we have excessive cholesterol in our diet, if we're taking too much caffeine, we're diabetic, obese, or restricted activity, those would be things that we could modify to at least some factors. Cholesterol, some of it is genetics, but also some of it is diet. And then there's non-modifiable risk factors that we cannot change. So age, gender, family history, race. There is some writings in the textbook that talks about how there's increased cardiovascular disease within some certain races. So looking at blood pressure first, what is blood pressure and what are expected and non-expected blood pressure? So expected blood pressure less than 120 over less than 80. And then we would have elevated if we're 120 to 129 over less than 80. Stage 1 hypertension, 130 to 139 over 80 to 89. Stage 2, 140 or higher over 90 or higher. So the reason that we ask you about these and ask you to memorize these numbers is because it would change the intervention. So if we have blood pressure in the elevated range, then they're going to look at like lifestyle modifications. If we have stage 1, it's probably lifestyle and 1 med. If it's stage 2, it might be lifestyle and 2 meds, or a multiple modal approach because of the staging. So we're wanting you to recognize these different stages and what's normal, what's abnormal. We can have signs of high blood pressure, so headache, lots of perfusion up to that brain, so they can have a severe headache. They could have chest pain. Vision, our eyes are very sensitive and have small vascular, so if there's a problem with flow, we could have some blurred vision, double vision changes there. Kidney dysfunction, we have small vascular in our kidneys. We could have affected blood flow with hypertension. We could have dizziness, fatigue, and then nosebleeds. So we want to watch for any signs of these high blood pressure. Patients might not know they have high blood pressure. They might be used to it, and so they might find it on screening. And then we're concerned about long-term hypertension causing damage to our heart, causing damage to our brain, our eyes, and our kidneys. If we have a hypertensive crisis, that's when our blood pressure is greater than 180 over 120. We can have severe headache, blurred vision, confusion, epistaxis, or nosebleed. This can occur when patients are newly diagnosed or maybe on a substance that raised their blood pressure. So we do want to ask our patient if they have any other problems. So like Cushing's can cause hypertension, tumor on their adrenal gland, pheochromocytoma could be another reason. So just like assessing the full picture. And then are they diagnosed with hypertension? Are they taking their medications? If not, is it a medication issue like an adverse effect like the cough with ACE inhibitors, or exercise intolerance, sexual dysfunction with beta blockers, or something else going on? They couldn't afford their meds or they forgot them or something. So we want to look to see if there's a reason why their blood pressure is high. And then we want to recognize the manifestations of that high blood pressure, administer IV antihypertensives as ordered. Hydralazine is a direct vasodilator, nitroprusside. They could put on clonidine. There's a couple different meds they could pick for a hypertensive crisis to get that blood pressure down. We don't want to go from 200 to 120 because that can cause swelling in our brain. So it's going to be done in a more controlled manner, that they're going to drop the blood pressure, decrease the blood pressure. They're going to check it frequently, every 5 to 15 minutes. We're going to monitor for signs and symptoms of a stroke. And then we're going to look at their EKG rhythm, make sure that we're not having any big changes with their rate, but also looking at their rhythm to make sure there's not a problem. Diagnosis for hypertension, 2 or more proper blood pressure readings in the office. They're going to make sure you're using the correct cuff size, that we don't have our arms and legs crossed, that we didn't just run in chugging coffee to get our blood pressure screened. And then they're going to talk about lifestyle modifications and or medication depending on the staging. We know that high blood pressure increases their risk of stroke. we want to decrease that blood pressure and decrease their risk of stroke. And then we always want to do some comparison. So if we're getting a blood pressure that's high on one side, let's check another extremity. Let's check the other arm to see if that blood pressure is high also. Just consider, like, are we doing this appropriately? And then it's usually 2 blood pressure readings that are elevated that would get them the diagnosis. We want to decrease your blood pressure, so they're probably going to be asked to come in and have their blood pressure checked in the hospital or get a blood pressure monitoring device for home and then keep track of them. Talk about decreasing their risks, like quitting smoking, increasing exercise, changing their diet, decreasing sodium and cholesterol to decrease risks. We'll talk about this in class. And then switching over to atherosclerosis, so that's plaque deposits in our arteries. It's a major cause of vascular problems. So you can see in the middle of the slide that we have a normal artery. Blood is able to flow through freely with oxygen and nutrients. Middle section, we see mild atherosclerosis, so we see some narrowing, and then we see some severe atherosclerosis on the far side. And so that significant narrowing that would affect the blood flow through those vessels, and your extremities won't be getting the perfusion that it needs. We'll have a video we'll watch in class. And then we want to complete history on your patient, monitor their blood pressure, check both arms, palpate peripheral pulses. Do we have nice strong +2 pulses, or do we have weak pulses? Do we have to Doppler these pulses? Auscultation for bruits, that's not something we usually train nurses to do, except for with the AV fistula, you could listen for a bruit. But providers will often listen for like renal bruits, they'll listen for carotid bruits. It's kind of like a noise that is higher sounding where their blood is like turbulent through that area because it's narrowed and it can't get through. But that's something they would also look at. And then lab values, looking at your lipid profile, looking at your triglycerides. Homocysteine level can tell us about cardiac risk, loss of elasticity, plaque formation, hemoglobin A1C, percentage of sugar on our red blood cells lasting 3 to 4 months, so it gives you kind of a longer picture of what's been going on with your patient. And it's typically they want the hemoglobin A1C less than 7 for diabetics. If it's over 7, poor control. And elevated glucose increases our risk of atherosclerosis. So risk factors, smoking increases our plaque buildup in vessels. What resources can we provide for patients? There's the quit line, there's medications that can be ordered, there's support groups. Diabetics are at higher risk for plaque buildup. How can patients decrease their risk? Looking at obese and sedentary lifestyle, what goals can we set? High cholesterol diet, what are some changes that they can make? So we'll talk more about these in class. We'll talk about this patient in class. And then looking at risk factors for peripheral vascular disease and coronary artery disease. A lot of the same ones for high blood pressure. So smoking, obesity, having a family history. Females are more likely to have some peripheral artery disease, Caucasians more likely to have coronary artery disease, advancing age, although you can see young people with coronary artery disease. I remember I had a patient that had open heart surgery. She was in her 20s, manager at a fast food restaurant, so they definitely looked at like cholesterol. They looked at her diet as being a big risk factor. But it's typically as we age, but there is exceptions to that rule. High blood pressure, diabetes, dyslipidemia, so abnormal cholesterol, LDL, triglycerides, sedentary lifestyle, and then stress. So dyslipidemia, any deviation from normal cholesterol ranges, we want that total cholesterol less than 200. The HDL is our healthy cholesterol. We want that higher. So 40 is acceptable, 60 is even better. So if we can get that HDL up, you raise your HDL by exercise and eating healthy fats like avocados. And then LDL, we want that less than 100, triglycerides less than 150. Peripheral artery disease, things that we would find, changes in their skin color, so dependent redness on their extremities, burning or cramping in their legs during activity that's relieved with rest, so that's called intermittent claudication. And when we are exercising or moving, then there's an increased demand for our body to move that blood flow around, have increased oxygenation. So if patients are having pain with exercise and then it's relieved by rest, then we're thinking that we have narrowing in those vessels where they're not able to get that good blood flow down to their extremities. Changes in their pulses, decreased or non-palpable pulses, loss of hair on their lower extremities, having cool extremities, or ulcers or gangrene on the toes. If you think about the blood flow through your extremities, it has to get down to those small capillaries to perfuse our toes. So if we're seeing ulcers down there or necrotic tissue, then we're probably not having good blood flow down to those lower extremities, and that's something that should be addressed because we don't want ulcers. Ulcers are really hard to get closed. Dry, scaly, mottled skin, or the 5 Ps: pulselessness, paralysis, paresthesias, pain, pallor. Diagnosis for a peripheral artery disease, ultrasounds can be really helpful, CT scans. Ankle brachial index is where they put a blood pressure on your arm, a blood pressure on your ankle. They take the blood pressure, then they do some math, and they give you like a risk. And if there's a significant difference between those two blood pressures, they're thinking that there's narrowing in the vessels. Plethysmography is looking at flow and volumes throughout the system. So that's another test that could give good information. MRAs and then angiographies, they can put a catheter in, introduce contrast into a different area, image it with x-ray and see that there's narrowing that needs to be addressed. So there's surgery they can do if they find that there's lots of narrowing. There's different interventions. And then switching over to venous, so I have found that students sometimes don't completely recognize what the arteries do and what the veins do, and how, if there's a problem with the arteries or if there's a problem with the veins, the differences that they would see. So arteries bringing oxygenated blood and nutrients to our extremities, veins bringing the deoxygenated blood back up to our heart to be reoxygenated. People can have venous insufficiency if they've had prolonged hypertension. They can have damage to the valves. Patients that stand a lot or walk a lot for their job, they might have dilated vessels and some problems with their venous extremities or venous system. So the blood pools and clots that can lead us to DVTs. They might also complain of edema. They can have brownish discoloration along their ankles, and they can have ulcers around their ankles. So the ulcers are different. The skin color is different. Now, that's not to say people can't have artery and venous issues. They can overlap. But if they were just having an artery issue, this is what it looks like. If it's a venous issue, this is what it looks like. So we'll talk more in class and do a little activity. So for venous insufficiency, things that they recommend to a patient: elevate your legs above your head, lay down, avoid crossing your legs or wearing restrictive clothing, wear compression stockings, put them on in the morning or when you first get up when swelling is decreased, and then it will help to move that blood flow, kind of adds extra support to your system. So I always recommend nurses wear these. Anyone that's on their feet a lot should wear compression stockings to help with that blood flow if you're standing a lot. And then coronary artery, that's that plaque buildup in the coronary arteries that supply the heart, can lead to a myocardial infarction or sudden cardiac death. We've talked about chest pain a little bit in the other class. So they're stable. You can anticipate that related to stress or activity. Unstable, it's all over. It's while you sleep. It's, hard to decide or know when it's going to occur. And then Prinzmetal is spasming of our vessels. They can have shortness of breath, fatigue, rhythm changes, and then people usually don't start to have symptoms until at least 40% or more of the artery is blocked. So we've talked about stable, usually occurs with stress or exertion. I told my classes, like when I worked in the cath lab, you would anticipate, more people complaining about chest pain when we've had a lot of snow and they're out shoveling, or when the Packers are losing or something like that. We would see more people come in after the Packer game because they don't come in during the game. They wait till after the game is done and then they'll seek intervention. It can be relieved by rest or nitro, lasting less than 15 minutes. Only symptoms is pain, chest, jaw, neck, or arm pain. And then unstable, that one's more concerning because it's occurring anytime with rest or exertion or without, worsens in duration and severity over time, can have other symptoms like nausea, epigastric pain, dyspnea, anxiety, diaphoresis, and then we can see some EKG changes, which we'll talk about in another week, ST elevation, ST depression. This could be a precursor to MI, should be treated as an emergency. Prinzmetal can also seem a lot unstable. The patient can have a lot of pain. They can have changes on their EKG. It's more of the arteries spasming versus that there's a narrowing or a blockage with plaque formation. So they're treated differently, but they would still want to intervene, diagnose it, do the gold standard, the cath lab to see what's going on with their patient. And then patient assessment for people having chest pain. We're going to do vital signs. We're going to look at what's going on with your heart rate. So is it increased? Is your respiratory rate increased? That's something that your body would do to try to increase the flow, the perfusion. They're trying to get more blood flow around to your body. And then do we have hypertension? That's a risk factor. Do we have low blood pressure? That could be related to nitroglycerin, antihypertensives, or morphine administration. So you're definitely looking for changes in vital signs. What's their pain? Having them rate it, describe it. When did it start? Does anything relieve it? And then looking at your physical assessment. Are they short of breath? Are they diaphoretic? Are they clammy? Are they pale? Are they nauseous? We're going to draw labs. We're going to start an IV, so serial cardiac enzymes, CK, CKMB, and troponin. It's usually every 4 or every 8 hours, like times 3, because they want to see, are they going to go up? Cardiac enzymes labs don't immediately spike up. So that's why you have to do repeat of them to make sure that we're not missing anything with that. So it does take a couple hours for some of these to elevate. BUN and creatinine, in case they're having a heart catheterization, they would get contrast. We want to make sure that they have some kidney function. If their kidney function is poor, then they can look at, changing the contrast, pre-medicating, doing some things to try to decrease the risk of contrast-induced nephropathy. And then looking at their other risk factors, is their cholesterol high? They would do a lipid panel or cholesterol levels. Is their hemoglobin A1C abnormal? Those are risk factors for cardiovascular disease. Are they a diabetic and don't really know it? Is their cholesterol high and it was never treated? Nursing interventions for patients that are having pain, monitor their oxygen level. We want to keep it above 93. Do that 12-lead EKG within 10 minutes of getting to the hospital or pain starting. And then we can know if there's ST elevation or ST depression. And then medications as ordered. So nitro, aspirin, morphine, oxygen, and then they might be put on beta blockers, they might be put on antihypertensives, starting a statin. So a patient might come in and not really have a history and have some chest pain or have an MI, and then all of a sudden they're on like 5 meds, where it was like a totally new thing for them. So explaining their medication is going to be important. Compliance with medication, just because you get prescribed a blood pressure medication and then you check your blood pressure and it seems like it's in the okay range. Well, there's other factors because it decreases risk of having MI and it does different things too. So making sure that they understand why they're on their medications and that they shouldn't stop anything suddenly. What to do if they have chest pain? Do they have a prescription for nitroglycerin? What is the protocol? Are they started on anticoagulation medications? If they had a stent put in, they're going to be on clopidogrel for a while. That decreases the platelet formation going to that new stent in the coronary artery that was used to open it up. So they might be on aspirin, they might be on clopidogrel, they might be on a new direct thrombin inhibitor or something like that. So do they have to be concerned about bleeding, injury? What are their modifiable risk factors? Can we decrease those risks? When should they call their doctor? And then cardiac rehab is exercise in a controlled situation where nurses are monitoring their heart rate, their vital signs, their EKG to make sure they can exercise safely, because that is a big thing that they push after cardiac problems, is that your patient should exercise, walk, ride a bike, swim, do some exercise. It will help to decrease some of their risks. Talking about valvular diseases, so our aortic valve is a high pressure system. It works really hard to help push that blood out throughout our body with every heartbeat. So we can have stenosis or buildup on those valves that make them not close well. So you can see on the slide how we have aortic valve stenosis, and it looks like it's not opening completely and it's not closing completely. The normal is above it for you to look at. So we can see signs of decreased cardiac output because that blood's not flowing through to your body. They can have chest pain, they can have murmurs, they can have abnormal heart sounds and crackles. If you haven't heard a murmur before, ask your clinical instructor if they have anyone that has any cool heart sounds while you're at clinical. Look it up. It's an interesting sound. It can be a whooshing sound, it can be a blowing sound, it can be kind of like a turbulent sound, but it's not that good, crisp, clear lub dub that we're used to. And then stenosis or regurgitation can cause heart failure in your patient. So if we can have fluid that's backing up into our lungs and backing up to the right side of our heart, so we can see different problems that occur if our valves are not working correctly. And then they might complain of shortness of breath, difficulty laying down, they might have syncope. Positioning will be helpful for them if they're short of breath, so we could raise their head of bed, monitor for complications, and then they can go in and fix this. They can do aortic valve replacements. They can do lots of interesting things, and we'll talk about that in a different week. Heart failure, kind of talked about this in the other class. It's where your heart is not pumping effectively to supply the body with oxygen. It is a progressive disease. We don't have a cure for this. It's going to be managing symptoms. And then we can have left-sided or right-sided heart failure. These are different disorders that increase the risk of heart failure. So hypertension, coronary artery disease, metabolic syndrome is when we have high blood sugar, high cholesterol, abdominal obesity, smoking, high sodium intake, inflammatory heart problems, dysrhythmias, or cardiotoxic substances. There are some substances that directly affect the heart, and so before they get them, sometimes they will have an EKG and an echocardiogram done. So chemotherapy, adrenomycin is like one specifically that I remember that is cardiotoxic. So if patients need to have that because they have cancer, usually they'll have an echocardiogram and some cardiac tests done to just get a baseline, and then they will need some comparison and watching for changes later on. There's a video watch in class. And then when patients have heart failure, they look at their echocardiogram, which tells us what their ejection fraction is. The ejection fraction is the percentage of blood that's ejected from the ventricle with each contraction. Usually they want the ejection fraction to be like 55 to 70. If it's getting low, like 40 and things like that, they might think of like having a defibrillator and pacemaker in case they have rhythm problems. So left-sided heart failure, I always think of that as a lung symptom. So left lung, they're having shortness of breath, they're having confusion, they're having difficulty breathing while laying down, cough, crackles, wheezes, bloody sputum, and then they can have cyanosis. So the left ventricle can't contract normally, it can't pump effectively to push the blood around, and then we can have where it's not able to fill appropriately or relax. Right-sided heart failure, they called it cor pulmonale. That was an older kind of term. And then this often happens because of left-sided heart failure. So left-sided heart failure affects the left side, then it causes problems with the lungs, and then we can have problems with right-sided heart failure. So patients can have left-sided heart failure, right-sided heart failure, or they can have both sides of the heart having failure. And then they see more of fluid buildup with this one, edema, congestion, ascites, enlarged liver and spleen, jugular vein distension, weight gain. So we see that with our right-sided heart failure. And then what is our treatment for heart failure patients? So diuretics to help get rid of extra fluid if they have extra fluid. Fluid and sodium restriction. So we talked about 2 grams sodium restriction typically. Fluid restriction could be 2,000 milliliters. Doctor will tell them what to restrict to. Elevating the head of bed for dyspnea, having oxygen, and then they're usually on a bunch of different medications. So they might be on diuretics and they might also be on antihypertensives that vasodilate our system. We might be on medications that help our heart pump more effectively, like digoxin or Milrinone. And then we want to maximize oxygen and promote comfort. These heart failure can be really distressing, where they're feeling really short of breath. They might be anxious too, so they might be on some other medications too. So we're always concerned about our kidneys. Some of our medications are hard on our kidneys. We talked about ACE inhibitors being great medications, but not always being the best for patients, especially if they are having some kidney problems. And they can be nephrotoxic. Monitor daily weight is going to be important. Look at intake and output. Assess for dyspnea or respiratory distress. Maintain dietary restrictions. We said that there was lots of dietary restrictions that could occur with heart failure patients. Encourage rest and exercise, and then provide emotional support. Unfortunately, when patients have a heart failure diagnosis, there's a 50% mortality within 5 years. And then we're concerned about fluid building up in the alveolar spaces. We're concerned about renal failure due to decreased blood flow to our kidneys. We want to talk to them about lifestyle changes, diet and nutrition, reporting chest pain, having their medications, taking their medications, and then going to cardiac rehab. And then they would also know what are the signs and symptoms of worsening heart failure. When I worked at Banner Heart, we had a heart failure educator. She would go talk to patients when they were diagnosed. She would go to like outpatient settings, like long-term care facilities. She ran classes. They had a workbook that was for heart failure, and it was like green, your weight's stable, you're not short of breath, yellow, you're having symptoms, red, go to the doctor or go to the emergency room. So we try to do a lot of teaching with heart failure because there is that increased mortality rate with it, and also it is an area where once patients are diagnosed with heart failure, they tend to cycle back into the hospital. So they really try to do a lot of good teaching up front to prevent exacerbations and readmissions. Dietary approaches to stopping hypertension. We know that hypertension can be part of heart failure to cardiac problems. So if we can decrease that, that would be helpful. And then the last slide is an activity we'll do in class.